The next presenter is Emily Gurley. She's going to talk about water-borne diseases in Dhaka, Bangladesh. Emily is an associate scientist in the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health, and she leads studies on the transmission and prevention of emerging and vaccine-preventable diseases such as Nipah virus, hepatitis E virus, and arbovirosis. She has worked in Bangladesh for more than a decade, and her interests include improving the communication and collaboration between field epidemiologists and infectious disease modelers and development of novel surveillance strategies. So thank you for being with us, Emily. The mic is yours. Thank you.
Thanks for the invitation to be here. It's really exciting to be in a room of folks with so many shared interests. So in choosing which disease to talk about, there were many options. Ultimately, I've chosen cholera. And if I'm an epidemiologist giving a talk about cholera in an urban-built environment, I'm really compelled to start with John Snow. I have no options. This, of course, is the famous map from 1854 with the Broad Street pump in the middle. This is a very nice map. The counted cases, you can see them here on the map to identify the hotspots of disease. We've made a lot of progress since 1854, though not quite as much as we should have, I would say. And many of our strategies for cholera still look like this. Think about the outbreak in Yemen going on right now, where this is a backbone still of what they're doing there. But we have come forward in a number of ways, and this is the Millennium Development Target, which was to have the population without sustainable access to safe drinking water. So we came together as a global community, made this a goal, and we actually achieved it. So well done. We're making a commitment to get people access to safe water. I've highlighted here sustainable and safe because I think we're still struggling with those. That's been highlighted before, not only in how we do that, but how we measure it. But ultimately, it was defined for these purposes as the proportion of the population using improved drinking water sources. So an improved source is one that's covered. It's not a lake, it's not an open, shallow well. It's something you would expect to be protected from microbial contamination. So you can see that there's still a lot of heterogeneity, inequity, and where people don't have access to safe drinking water. But in many countries of the world, looks pretty good. But we know, of course, that within each of these political boundaries, there's substantial heterogeneity and access to safe water. So I'm going to talk about Bangladesh, which is right here. It's in light blue, looks pretty good, right? 175% with access to this improved drinking water sources. But some reasons to be skeptical. So let me introduce you to Arichpur. This is the community I'm going to talk about. I've been working in this community since 2009 on waterborne infections. It's primarily on the right side of the screen where you can see it's densely populated. It's about an area of 0.5 kilometer squared. The population density is about 100,000 per square kilometer, so roughly 50,000 people living there. With not many high-rise buildings, different than Hong Kong. And I've shown you what's next to it. So if you see on the left side of the screen, looks like a big open field there. And that is a campground. It's where the Bijwa Ijtima takes place every year, which is the largest gathering of Muslims around the world. 5 million people converge here from Bangladesh and 150 countries around the world every January. So you're all connected in some way to Arichpur, whether you knew it or not. You may be familiar with the degrees of separation from Kevin Bacon game. You can think about how many degrees of separation you have from Arichpur over dinner this evening. So let me tell you a little bit more about Arichpur. It's a very wet place. So on the southern border, there's a river, there are monsoon floods, and there's poor drainage. So as you can see in the upper right-hand side, there's a lot of flooding that goes on in the streets. It makes it difficult to navigate sometimes. Despite all the water, it is hard to get safe water to drink. So I told you that there's been a lot of work to improve access to water, see these improved water sources, and the majority of people living here do have access to improved water. They are using mostly municipal water supplies. But how safe are those? So these municipal water supplies have been there for a long time, but of course the population's grown faster than the supply and infrastructure can keep up. So folks there have done what any of us would do. They find where the main water line is, and if they don't have their own access, they make one. So you end up with a lot of breaches in these pipes, which make them very vulnerable to contamination. So if you look here in the bottom, this photo, so this is a sewer running, open sewers run through the street, and this is a pipe or more like a hose, that someone has connected to a main water line, and they're running the municipal supply water to their house. So it works good for those purposes, but a lot of opportunities for contamination. And in fact, when we first started working here, it was because of a hepatitis E outbreak, which was also spread through contaminated water. There was a mass contamination event in the municipal water supply, which is a very efficient way to get hepatitis E throughout the whole community quickly. So we had about 4,000 cases. So when we started thinking about cholera within this environment, we knew that there was risk, but we wanted to better understand what were the drivers of those that risk. And so in order to do that, we have to improve surveillance. We have to be finding cases if we want to study them. So we've toyed around with a couple of ways to do that I'll tell you about. And we wanted to also be able to predict areas where populations are at highest risk. So even within this community, can we identify places where we're more likely to see cholera or where risk might be higher? So surveillance for cholera now, right? The standard is that you wait for folks to show up at a health facility. They're usually quite ill. Many of them will get tested for cholera, and then if you diagnose them with cholera, you've got a cholera case. That's the way most of our surveillance cholera works. It's unsatisfactory for a number of reasons. One, you only see the severe cases, particularly in places where people have lack of access to care. Two, it's not very timely. Maybe once you're seeing that many severe cases, there have already been a number of other cases in the community, and maybe you've lost an opportunity to prevent the outbreak. So we came up with what was the cholera surveillance wish list. What would we ideally want? We'd want a system where you could identify the etiology, so not just asking about diarrhea. We'd want to find mild and severe cases because we want to study all of them. And we want as close to real-time notification as we could get. So our first pass didn't include all of these, but we decided that we'd try to use pharmacies, or really drug sellers, to try to see if we could look at oral rehydration solution sales as an early warning system for cholera. So this is Arichpur again here on the map. And you see all these orange dots. These are all the drug sellers that we enrolled in this surveillance study. There were 50 in the study out of about 120 we identified in the whole community. And what we did was ask them at the end of every day to send us an SMS message with the number of ORS packets they sold that day. And then we compared that to the traditional surveillance cholera system that we already have in place in Dhaka at the ICDDRB where I worked. And here's what we found. So I'm going to walk you through this. On the very top are the number of total diarrhea hospitalizations that we saw, and the total with cholera, which was about 22%. So along the top here, right, you can see over the course of the study between April and October 2013, all of the cases we found when we found them. Along the bottom, you can see high and low sales for ORS. And each row here represents one of the pharmacies or drug sellers and the number of packets they sold throughout time. So if you look broadly at the pattern in the middle, you can see that there are two concentrations of red, which mean high sales. One sort of around here, and the other one around here. Okay? So what that tells you is that there was a seasonality to ORS sales, and that seasonality corresponded with the seasonality of diarrhea and cholera that we saw. You'll also notice that the red tends to be more on this lower side, and up here with some blue here and blue here. That's showing you the spatial distribution of cholera sales. So we've aligned all the pharmacies here based on where they were in the community. And then that's also showing you that there's spatial heterogeneity and where the ORS packets are being sold. And that also corresponded with where we found diarrhea and cholera. So in the end, did this work? Yes, we found significant correlations between ORS sales and cholera, but it's not going to be a great predictor for us for a few reasons. One, it was able to give us an early signal just one day ahead of the cholera that we saw, and two, the data are really noisy. The ORS interventions in Bangladesh have been really successful, and people drink it like Gatorade for everything. So this isn't just for diarrhea treatment. This is if you've been sweating a lot that day. It's easily accessible. So this probably isn't going to work. It's probably not specific enough. But we kept trying. Here's try number 2, same community. This time, the methods were a bit different. So we actually enrolled a cohort of households, 400 households, because we wanted to follow people over time. This was nested within a study where we were looking at access to water and wanted to look at cholera and diarrhea risk. We called this intervention for surveillance the Choleraphone. And what we did is give every household in the study a phone that was recharged every month, and we asked them to call us when they had diarrhea. And if they called us, we visited with a healthcare worker, we gave them some ORS, and we also asked them to self-collect a rectal swab. We compared the incidence of diarrhea that we found through this, through the Choleraphone to a household survey, the standard survey that you would do in this setting, and this gave us etiology. We were hoping it would give us that real-time picture of what's going on. So some improvements over our last try. And this is just showing you the flyer that we gave out to those hospitals explaining when, or those families, telling them when we wanted them to call. So how did this work? So first I want you to just look at this figure. So in gray, where each of the bars start, is when we enrolled one of the households. So we enrolled a lot of households, and I want to point out the dots here. The green dots are households that dropped out. So they said, stop coming to our house. So there are quite a few of those dotted throughout. The green dots are those that moved within the community. So a lot of people dropped out. Most people dropped out because they left the community, and then the others were moving within the community. So I just want to point out that this is a really difficult population to study. They're highly mobile. Every month, people were dropping in, coming out, moving even 2 blocks down the street. So they're really difficult to study and keep up with. But ultimately, did they report diarrhea through the phone? Yeah, that's all the purple dots there on the right side. There are 2 bars you'll notice here in the middle. That was political instability where we couldn't get to the field, another complication of working in this setting. But yeah, they reported diarrhea. But it was a lot less than what we expected. And it was about half of what we measured with the survey. I suspect when you show up and ask someone to self-collect a rectal swab, there is a negative incentive to call back. I fully accept that. And it may be a fatal flaw in the surveillance plan, but we tried it anyway. Okay. We also, in this study, looked at clustering of risk. And I mentioned this to you already. We saw that there were clusters of cholera cases in time and space. We saw 2 in particular that are just highlighted here on the map. Cluster 1 is here. Cluster 2 is there. But we were also interested in clustering of risk factors within this community. And so for every confirmed case that we found, we enrolled spatially matched controlled households. And then we compared households distributed throughout these communities and looked for spatial clustering of what we consider high-risk factors for waterborne disease and cholera in particular. And we found that there was a lot of clustering. So I just will show you here, give you an example of how to interpret this. So the blue means that things are very spatially clustered. And so, for example, if you look down here at 9, households that had unavailable soap were highly clustered with 2 here, those using pit latrines. So we saw that spatially, those risk factors were clustered together within households. Even within this area of high risk, we saw pockets that were at much higher risk than others, based on what we know about transmission. So in summary, we've got to be doing better than Jon Snow, right? It's been 170 years already. And I think we can do better by appreciating and understanding these substantial and important spatial heterogeneities and risk, even within these communities, because we can target those clusters of exposure for interventions, such as the vaccine. We have good vaccines now, and we're struggling still with how to deploy that well and in a timely way. We're thinking now about seroprevalence surveys. The assays are quite good. That could tell us where people have been infected previously and help us think about risk going forward. We need creative surveillance solutions, and those are likely to be context-specific. What works in Arichpur may not work everywhere else, although I hope our lessons learned could be valuable to you if you're embarking on this. And just in terms of pharmacy surveillance, we're interested in looking at intravenous fluids next. These drug sellers will also hook you up to an IV if you're feeling particularly sick, and so that might be a more specific thing we'd like to try next. How do we sustain the improved water the gains in improved water source access over time? That's something I think we're still struggling with, and I think we need to accept that ultimately we are reducing population level risk to some of these diseases, which in turn is going to create large pools of susceptible people, so that breaches in these municipal water supplies and other water sources, contamination, can cause even larger outbreaks than what we see now in places like Dhaka, where people are regularly exposed. So that's it. Just to acknowledge all the very smart people that I work with on cholera. Thanks.
Thank you very much. Creative surveillance solutions. So tomorrow we'll discuss some solutions. So very good.